Kia ora koutou, everyone. Good afternoon. I'm Simon Bowen. I'm the Director of Health Outcomes for Waitemata and Auckland District Health Board. It's my great pleasure to introduce you today to the inaugural Health Outcomes Grand Round. We've got a number of distinguished guests here today I'd particularly like to welcome. Elsa Clare, our Chief Executive, is here, as are a number of other important and distinguished people, so welcome. I'd also like to acknowledge and thank Dr. Julia Peters and Holly Copen, who have organised this event. Thank you very much. And this is meant to be the start of an ongoing series that will enable us to have a greater focus on the big population health issues and challenges facing us in Auckland. And it's intended to be a way of engaging staff both within the DHB as well as engaging staff within the DHB as well as the broader health and public sector in addressing these big population challenges that we face. So we're starting here today with a focus on obesity. As I'm sure you're all aware, this is a massive and growing challenge for us. Almost a third of adults in New Zealand now are obese, and a further 34% are overweight. According to the Global Burden of Disease study for New Zealand, high BMI is the second most important modifiable risk factor in New Zealand, and if current trends continue, it's predicted to overtake smoking as the most important factor by 2016. The costs of obesity are high and increasing, both to the individual, the health sector and the broader society, and to date our efforts to tackle obesity have at best been modest. So we're very much in need of some bright ideas, some energy, some momentum to tackle this issue. We're really delighted to have a leading academic and a leader in his field in this area to talk to us today. I believe that this will be someone who will give us great insight and energy to help us address these big issues. So it's a great pleasure to welcome Professor Boyd Swinburn. Boyd is the, just get all the details right. Boyd is the Professor of Population Nutrition and Global Health at the University of Auckland and the Alfred Deakin Professor and Director of the World Health Organisation Collaborating Centre for Obesity Prevention at Deakin University in Melbourne. Boyd, welcome to Auckland DHB. It's an honour to have you here, and we're all really looking forward to hearing your presentation. Thank you.
I think this is a great innovation to look at the bigger picture, and I think it's really important. Of course, I think it's very important because I work in population health, and that is dealing with the big picture. So I'm going to talk a bit about obesity. This is pretty topical at the moment because it is something that's got a little bit of a political boost recently, and I think there's a political opportunity here that we need to take advantage of. And tomorrow there'll be a budget coming out. Tomorrow, it is tomorrow, isn't it? The budget will be coming out, which hopefully will have some more details around the Healthy Families New Zealand. So I'm just going to talk a little bit about the problem. I know you see it coming through the doors every day in the hospitals, but I just want to give you a bit of a view about where we stand globally. In terms of the solutions, there's many different ways to cut this. The way I've cut it for this particular purpose is to talk about the sort of hard policy approaches around regulations and tax options, community-based approaches, and this will focus on the experience in Australia and what that might look like coming to New Zealand. And then there's some specific population factors, particularly socio-cultural factors, which I think need to be addressed specifically. And then I'm going to turn to how this could work in Auckland. We do have this Healthy Families New Zealand on the horizon, which, as I said, is an important opportunity. And what's Auckland's response going to be to this, and how we're going to capture this opportunity? So, as Simon said, we've got 30-odd% of men and women overweight and obese, and it's increasing. And in fact, most countries are like this for adults, are just increasing. There's no country that's been able to turn this around apart from Cuba when Russia pulled the money out of it and went into economic collapse, and Nauru when they they ran out of phosphate and went into economic collapse. But there's no country that has turned around adult obesity. Currently, out of the wealthy countries, the OECD countries, we're a bronze medal at the moment on the podium, just behind Mexico and the US. So New Zealand is considerably fatter. It's fatter than all European countries, and almost all the other wealthy countries, which shows how little we've been able to achieve in this country. In terms of children, these are data on for European countries. A number of them don't have data, but this is where New Zealand sits. And in fact, if we use the same definitions as they do in Europe, the WHO definitions, it would be considerably higher. So I think for kids, our kids are fatter than any other European country. This is not a good gold medal to have, guys. Some of these countries are starting to flatten out in their childhood obesity. So you can see here the US and the UK. So the US in pink and the UK in blue. And you can see the big rise over the 70s, 80s, 90s, and over the 2000s it's flattened out, even in the US. Now, I'm not confident that in New Zealand we've seen this flattening. We do have annual measures of childhood BMI, and while there's no statistical increase, the numbers are a bit small, and there's still, another 10,000 every year kids being classified as overweight and obese. So I'm not confident actually that in New Zealand that we've even plateaued. Australia doesn't have very good monitoring systems either, but putting together a number of studies where they've measured the same population at 2 different time points and putting them together like that, you can see that Australia's probably plateauing as well. So just a little bit update, Simon, from the figures you quoted, which were the New Zealand analysis of the burden of disease 2006. This was an update for 2010, and this is a whole bunch of preventable risk factors here across all of the sub-regions, and this is Australia and New Zealand, Australasia, and high adult BMI is the #1 risk factor. It's the #1 risk factor in Australia and New Zealand, and the burdens as calculated by the global burden of disease. High BMI has just overtaken tobacco here, and for the first time they've joined together the poor diet ones, because in this list here you're not going to be able to see it, but there's a diet low in fruit and vegetables and high cholesterol and high blood pressure and high BMI, high fasting glucose and things. So there's a number of risk factors there related to diet, and when they kind of combine them with a little bit of magic, a little bit of epidemiological magic, the level's about 11%. So this poor diet is I think the highest preventable risk factor in New Zealand, and we need to have serious attention on diet. We think about diet and obesity and things, but actually diet has many other consequences, including mental health actually, as well as oral health that you know about. But mental health is much stronger evidence coming out now about the effects of junk food on having poorer mental health scores, on quality of life indices, and healthy food having higher scores. And interestingly, they're independent of each other. I'll come back to this a little bit later, but you know this well. These ethnic differences in overweight and obesity in children and in adults. So I'll come back to that a little bit later when we talk about the socio-cultural components of obesity. Now, just a word about how this epidemic has increased and what it's likely to happen when it decreases. So these are data from the US, in Haynes data, and each line is an age group taken over several different periods, and you can see that each age group has gone up over time in parallel. Now this is the classic environmental influences. This is not a cohort effect. There hasn't been a whole bunch of fat kids that have come through the system and now fat adults. This is something which is environmental, which has affected every age, and we've all got fatter together. When it comes to turning it around and going down the other side, because we now have 2/3 of adults overweight or obese, the adult problem is a weight loss problem. And weight loss is bloody hard. And a lot of people fail at it. And I don't see myself that the turnaround is going to be the equivalent picture of this where everybody goes down together. It's going to come from the kids first. We're going to have a big cohort effect on the downturn of this epidemic with the kids coming through first, so there will be quite a big cohort effect, which is problematic for places like the hospitals, because there is this large mass of people with overweight and obesity that are going to keep getting diabetes and coming through the door. Okay, these are the causes of obesity, which you may have seen before. It looks complex, and it is complex, but it has a kind of a logic to it. Here is the energy balance part, the engine, the energy in and energy out. Here's all the physiology down here which influences that. And interestingly, when you look at the health literature, at the medical literature around obesity, where are we putting our research dollars and our research efforts? It's down here. It's trying to understand all these mechanisms. I spent a fair bit of time doing that myself until I realised that actually our physiology is perfectly normal. And the pathology is outside the individual. The pathology is in the environment, the obesogenic environment. And yet we still spend a lot of effort looking down here for new molecules and God knows what. Here we have food consumptions affected by the food production. Here we have physical activity affected by the physical activity environment. Here's the person's individual psychology affected by the socio-cultural environment. So it does have a nice order to it. When they first built this map in Foresight in the UK, they thought, and it took them a couple of years, as you might expect, they thought what we need to do is to understand what the causes of obesity are, and then that'll tell us where the solutions are. So by the time they built this thing of the causes, actually it wasn't all that helpful for telling us where the solutions were. It was very helpful to show that everybody's involved, every sector's involved. You can put just about every government department on this map somewhere. So you know it is critically important for that. But in terms of helping with the solutions, not quite so much. This is how I think about how the problems and the problem and the solutions join together. So let me just, and I haven't got time to give you all the kind of evidence behind this, but let me give you the sort of the summary. So here we have energy imbalance, and I believe the energy is showing that this is a push factor. This is driven by energy intake, by high energy intake. And it's high energy intake, so it's positive energy balance pushing the energy, positive energy intake pushing energy balance, high consumption of energy dense foods. If you jump over to here, the drivers of that are our food supply. Our food supply is increasingly manufactured, processed foods, energy dense, highly promoted, highly palatable, cheap in price, readily available, and so on. All of the things that influence our behaviours. So this here is the direct driver. But as these energy drivers, and you see this across populations, as it hits different populations in different countries, it has actually a differential effect. Some populations respond enormously to it and others respond less. Some are more protected. So there are socio-cultural, socio-economic, recreation, transport environments which either amplify or attenuate these drivers. And right back here at the systemic drivers, we have the whole economic and policy environment that we're built on around the idea of growth, around economic growth, which is built around the idea of consumption, or is driven by consumption. And if the private sector is doing its job well, then we end up over-consuming, and it's not just food, we end up over-consuming all sorts of things. So that's the kind of simplified diagram that I keep in my head. Now, what about the solutions? Well, we can do some drugs and surgery down here, which I'm sure you probably know about. We have a bunch of health promotion programs and marketing, social marketing, which can try to influence behaviours and have an influence on these environments. And then there's a bunch of policy regulations, policy interventions, regulations. Now, obesity is somewhat different to other public health epidemics that we have managed to get on top of. And if you think of infectious diseases, if you think of road injuries, if you think of tobacco and cardiovascular disease and occupational injury and so on, those are problems which, while we may not be totally under control, at least are kind of coming down and heading in the right direction. Now, for almost all of those, there are some regulatory approaches, these policy approaches here, under policy interventions, which have an effect directly on behaviour. So, like, I can't light up a cigarette in here. There are rules around how I drive on the road. There are rules around alcohol which affect my behaviour. But in this space, for obesity, there's no regulation that any government can write that tells me what I have to eat for breakfast and whether I go for a walk or not. So we just don't have those regulatory policy options that directly affect behaviour. The only opportunity is through environments indirectly to influence behaviour. So that does make the job a fair bit harder, I think, compared to other problems we've dealt with. The other thing is that the importance and the difficulty in interventions increase as you go to the left-hand side, and which is why we spend all of our time working down here in the behaviours and programs and treatment side. Stuff right up at this end, my goodness, trying to influence our economic systems and growth would be a real challenge. But we do need to push our interventions much further up into the environments. And in this world of evidence, as you shift to the left-hand side, the evidence uncertainty gets greater as well. You know, what's the evidence that affecting stuff right up here around these drivers is going to have an effect right down here is much more uncertain than some behavioural or surgical intervention. So, you know, if you want to get to where the really important interventions are, it's tough. It's a tough ask. Okay, so if we start off with a question about kind of what needs to be done, if you're looking at this kind of big picture, what needs to be done? And I think in general that's been answered. And we've got lots of WHO documents and plans and declarations, and we now got the Global Action Plan 2013 to 2020 for NCDs with targets and monitoring frameworks and all that sort of stuff. So at a high level, and you know, New Zealand signed up to this and countries have signed up to this, at a high level, we kind of know what to do. The direct translation of what those high-level statements are down to actually what happens on the ground is a translation issue, so we have that to do. But in a general sense, I think what needs to be done is pretty clear. The challenge is how to do it. When you distill from those documents and other high-level documents, what are the top 5 or 6 policy areas we should be operating in for obesity? These are the ones that kind of come up. Reducing junk food marketing to kids, and that has to be a regulatory approach. I think we have good evidence that non-regulatory approaches are a total failure. Tax on unhealthy foods, and at the moment I think taxes on sugar-sweetened beverages is the best target, better than taking the GST off fruit and vegetables, or better than saturated fat taxes and so on. Interpretive front-of-pack labelling, and that has a fair bit of a history here, but I think we're getting close to that, largely because what's been driven in Australia with this health star rating system, which I'm hoping is pretty close to completion, and if Australia goes for it, I'm sure that New Zealand will. So that's a good option. It's going to start off as voluntary and then go to mandatory if there's not wide coverage. And those ones are all kind of, the jurisdiction for those is national. So at an Auckland level, for example, we don't really have jurisdiction over those. All we can do is try to create pressure for them at a central level. But these other ones, public sector healthy food service policies, active transport policies, active recreation policies and opportunities, they are actually in the hands at a local level. And so there is a lot that can be done there. And this public sector healthy food service policies is actually really important. This is, if all the people who are employed in the public sector and all the money in the public sector that went to food was for food that matched the dietary guidelines, that would be huge international leadership, institutional leadership, I mean, in terms of showing the way. So I think hospitals led the way with smoke-free, and before it became regulations, and the same is starting to happen, I think, in some settings. But it's patchy, it's local. There's no kind of national driver for it, but there's a lot of opportunities there. Active transport policies and recreation policies typically have local jurisdictions. So there's a lot of opportunities, I think, for doing that. Part of the problem with some of the transport and recreation things is that this is dealing with the built environment, and the built environment can be quite slow to change. Some aspects can change faster, but Auckland is a car-dependent city, and it's going to be a while before that changes. A lot of these policies and potential interventions have had modelling for cost effectiveness, and we've done quite a bit of this work, and there's some work we did in Australia. And a bunch of them turn out to be cost-saving to the health system, a bunch of them are cost-effective, and a bunch of them are not cost-effective. Now, when we did these analyses and were sort of promoting them within Australia, there were a set of interventions that the government in Australia clearly did not want to do. They were clearly off the table, and that they were those ones. And there are a bunch of interventions that the government was already funding, and it was those ones. And this is the story across the world in terms of implementation of policies. The soft stuff, the easy stuff, the walking school buses and that sort of stuff, it seems to attract the money. Politicians don't have any problem with doing this. The Active After Schools program was John Howard's approach to childhood obesity. Just give $100 million to the sports organisations to get them to do active play after schools. I think this type of approach is valuable, and then it does take all of these dozens of different interventions. It does spread them out. So in saying if you're interested in cost effectiveness, actually they're not all the same. They're really quite different. But the problem remains that these ones at the top, the most cost-effective ones, are the regulatory ones where there is the strongest opposition from the food industry and also from market ideology people and politicians. Okay, there's also a history to the process around what happens when we try to go through a government process for getting comprehensive action. We saw this with the inquiry that Gabrielle Jenkins analysed for her PhD, the inquiry into parliamentary inquiry into obesity and diabetes. And there's a spectrum of world views on the problems and solutions, and you can get that from reading the submissions. And the public world, health world, sits here with the collective responsibility, policies as a priority, regulate the industry, and the industry sits over there. Individual responsibility, education as a priority, industry self-regulation. So Gabrielle followed the process of this inquiry, and there's exactly the same thing that happened with the Preventive Health Task Force in Australia. The report that comes out from this is actually pretty close to the public health end of the spectrum, pretty close. The government response, in terms of describing the problem, is a little bit shifted towards the industry, and the solutions are a bit further shifted towards the industry. And then 5 or 6 years later, when you look at what actually happens, almost nothing of the tough stuff that in the regulatory sense has come out gets implemented, and we end up implementing some of the softer policies. So that's kind of the nature of the process, the policy process, as it happens at a national level at least. So those are the policy kind of issues, and there's a lot we can have a lot of debate about those. But I want to just come down to the community-based approaches and talk about some of the work that we did around. We took 3 whole of community obesity prevention programs in the Barwon Southwest region. So this is this part of Victoria. 2 of them were in Geelong and 1 of them was in Colac. And we took the intervention that we implemented over this time was building community capacity. That was the intervention, building community capacity. We didn't go with a bunch of programs and a bunch of things. We went there to support the leadership, to reorient the resources, help them get their structures in place. And we had 3 different age groups: preschool, primary school and secondary school, but it was a whole of community approach. So this is the first one, and there's some lessons in all of these for what might happen in New Zealand. So this is the first one, was under 5s in Geelong. So the 12,000 children under 5 in Geelong. It's a city of about 200,000 people. And we had virtually no money for this. We thought it was a good idea. We had $100,000 over 3 years for 12,000 kids to try and prevent obesity. We had some seconded people, and we had multiple agencies and coordination and policy. We had to do the cheap things because we didn't have any money, which were policies and training. And we didn't have any money for evaluation, and so we had to use population monitoring data, so the equivalent of our before school check. We were able to extract that data from Victoria, just like the before school check here. You know, stuff that gets done within the health system doesn't get pulled out for monitoring. So we went in and dug it out, so it was cheap evaluation. And you can see here that the intervention over 3 years had a significant effect in reducing prevalence in 2-year-olds and 3.5-year-olds compared to the rest of the state here. So important lessons for me from this were actually you can get a lot done without a lot of money, because prevention is relatively cheap in the scheme of things. We're now going back into this study because we have an NIH grant to examine systems approaches to childhood obesity. And when NICE, the National Institute for Clinical Excellence in the UK, was looking for examples for systems-based approaches to childhood obesity, this was the one that was the most like a systems approach. And so we're now going back to look at what actually were the markers of success in this. And when we go back and read the minutes and read the reports and things that were coming out, it was a bloody mess. You know, there were agencies banging into each other, there were you know, logos banging into each other, there were issues around the coordination and whose responsibility is this and who's going to take leadership. And, you know, it was, reading the minutes, like a bun fight. But actually it got there because there was something that driving it. And I think this is important to keep a hold of. This stuff is messy to do. The importance of the monitoring stuff. So this is the data we dug out of the Victorian system and actually showed, over the last 10 years, this population has been decreasing. So the under 5 is going to be the first population to turn around. And this is why we need to grab the type of data like the before school check. The next one is Colac, which was the Be Active, Eat Well, the longitudinal design. Over 3 years, reduced the weight gain by about 1 kilogram, 3 centimetres around the waist. Seemed to have a bigger effect in lower SES children, which was pleasing. And we did a whole lot of safety measures. You know, does this cause more dieting or more distortion around your body size and all that sort of stuff? And we found no difference at all. So I don't think any of these community-based programs cause any harm that we could measure. And we had questions about sustainability. So you run this program for 3 years. A bunch of money comes into a little town of 10,000 people. They do a fantastic job. They get a great result. Is it sustainable? There's 2 sustainability questions. One is in the individuals. Does those kids carry that now reduced weight? Do they carry that with them through time? And actually we haven't measured that, but we did measure it in the community. So we went back 3 years later. So this was 2003 to 2006. We went back 3 years later in 2009 and compared how Colac was going with the rest of the region. So let me just walk you through this. So this is a spidergram of measures of community capacity, and here are each radial arm is a factor: partnerships, knowledge transfer, problem solving, infrastructure, financial investment, and so on. And we take measures of that. And here was Colac at the beginning. So the further out you are, the better your capacity. Here they were at the beginning. And then when we measured them 3 years later at the end, they were this dark blue line around the outside. So that increased capacity a lot, actually. And then when we went back 3 years later, this little fine dotted line is their capacity. So that it dropped down a little bit, but not much. But then look at the capacity now of the rest of the region, which was the comparison area. Over that time, and unfortunately we didn't have baseline, so we don't know what they were like at baseline, but we're assuming they were no different from Colac. But these guys in the comparison area, all around Colac, have lifted themselves up by the bootstraps and got their own capacity. And when we did a financial analysis, looked at what the investment was, an economic analysis, what are you now investing? Here was the investment, and this is per school, in Colac during the intervention, and of course there was not much happening in the comparison area. And then 3 years after, we had this, post-project slump, which you see with projects, and it's a problem with projects. Projects have a start and an end. A post-project slump, but they were still investing. But look at the comparison area. They picked themselves up by the bootstraps. They were well networked. They knew what was happening. They reoriented their own systems. They mobilised their own resources and picked themselves up. And actually were now actually doing better. This is the second time I've had control groups do better than intervention groups. I think there's some message in this. Anyway, so this is comparing, this is the start, 2003. We had to compare it with the start because this was serial cross-sectional. The start at 2003 compared to 6 years later. Here's Colac. This is healthy weight, overweight, obese. So they reduced overweight and obesity by 6 percentage points, and the region reduced it by 10 percentage points. So there's something spilling here. The obesity prevention virus can get out through the networks. And this is the value of a systems-based approach, because networks are integral to systems. And while this is terrible for scientists, because we call this contamination, we don't want this stuff, our control groups, to be contaminated. But for health promotion, this is perfect. This is exactly what you want. And there's interesting lessons in here. We're going to have 3 projects happen within the Auckland region with this healthy families, where they're going to get a bunch of money and then the money's going to stop at some stage. There's some lessons in this for what the wider Auckland region does. Okay, It's Your Move was a secondary school program, and again, over 3 years, had significant effects. So here's the intervention group, reduced prevalence by 3.5%, and up goes the comparison group by 2.5%. So the changes we found in this were directly proportional to the changes in capacity, and we took the same community capacity building approach and we tried this in Fiji and Tonga and South Auckland, Mangere, with a high Pacific population. Exactly the same approach that's had these positive effects that I've shown in these last few slides. So this is just to show if you measure community capacity. So here's the change in community capacity. So this is no change, in the ones with the open boxes were the comparison schools. There's a comparison school, and here was a +1, +2, +3 increase in comparison in capacity. And the schools that had the biggest change in capacity were the ones that had significant reductions in overweight and obesity prevalence just over those 3 years. This is 4, 5, 6 percentage points, not relative percentage. Over this time. And you can guess what the key factor was here was the school principal. So, it comes down to the individual and the driver on it. So here's the one I've just shown you, the Australian one in overweight and obesity, significant effect. When we took exactly the same approach to Fiji, Tonga and South Auckland, no effect. Zip-diddy-doo-dah. And even Tonga, when we started off, 55% overweight and obesity. 3 years later, blood, sweat, tears, lots of programs, I can show you 1,000 photos of all the great things that happened. They were 65% at the end. So we can't rely, you have to do hard outcomes data because you can fool yourself so easily that you're doing great things. And this is very sobering, I have to say, and tells us the size of the challenge with, particularly with Pacific populations, but others as well. And those of you that you know, work in this space and know people, there are big socio-cultural factors, and we did a lot of research on what those were. The biggest one by far is the role of food, and the sort of volume of food that's used as a currency for showing love and caring and sharing and hospitality and status and so on. There's quite a bit around body size perceptions, around the reflection of body size as a reflection of beauty and being looked after and wealth and health and so on. The value of physical activity, and this is particularly around competing priorities, homework, cultural and religious factors. And we didn't do much work in the parenting styles, but others have, around different types of parenting approaches, some of which are kind of culturally determined. So this is a very important set of factors which are big determinants of energy intake in particular, but also physical activity. And if we don't centre the interventions around this, then we're, for these populations, then we're in trouble. Okay, so what is a systems approach? And we kind of label this the sort of generation 3, you know. So the first generation of studies was the kind of, you know, I'm an academic, I'm an expert, I'm going into a school, I'm going to do a cluster randomised trial with a program that I've developed because I'm a phys ed expert, and here it is, and we do it and get it published, and it has an effect, and then it goes nowhere. That's the first generation. Second generation is the type we did, those kind of community-based stuff. But the third generation is a kind of an integrated systems approach, and this is a step change. It's a step change in thinking. While we were kind of close to it in what we did, we hadn't articulated it as systems, and I think it is another level. So these interventions, they're not bringing programs or whatever, they are working within and sometimes upon the existing systems. The system's already there, you need to know them and understand them, or at least work with the people who do, and work out where those levers are for change. And it's the only way that we can get scalable effects. So the question is, how can multiple systems be strengthened to prevent obesity? That's the research question. It's a different type of research question. It needs different methods to what we're used to. The null hypothesis testing methods that we're used to are not very suitable at all. So things like network analyses, systems modelling, agent-based modelling, continuous quality improvement. There's a whole bunch of tools out there, not commonly used in health, but used in other places like engineering and business and so on. We need to adapt. We need to pay the systems. It sounds a bit waffly and sounds a bit fuzzy, and we all think we know what we're talking about, but what it means is you need to pay attention to what the system's building blocks are, dynamic effects, implementation processes, feedback loops are really important. That leads to non-linearity and adaptation. Networks are pretty critical. This is the only approach I think that's scalable, and so if we don't take that, we're not thinking at scale. And so if we build the full prevention house, what we're used to thinking about is what are the services we're delivering, what are the programs we're delivering, what are the specific policies that we're implementing. These are still important. They have specific actions affecting people and their food and physical activity environment. They're still important, but this has been our kind of sole focus a little bit up to now. We need to shift to the back of the house. These are the system and capacity building blocks. And this is what we were kind of, this was when we said we were building community capacity. These were the things we were trying to do. Strengthen leadership, governance, information systems, mobilise finances, strengthen networks, build workforce, and that sort of thing. So paying attention to these. At the top level is the high level policies, the political commitment. Australia, it came through the National Preventive Task Force, or the National Preventive Health Agreement, which was a bunch of money, about $1 billion over 9 years. Last night just got shaved by the Australian budget. They whooped $370 million off it from the Abbott government. So these things are very prone to losing money. But nevertheless, this high-level political commitment is a real political opportunity, and we've got that at the moment, I think, with the healthy families. And then if you want systems dynamics, you just grab 1,000 arrows and you just stick them everywhere and try to make sense of it. You know, we're trying to do that at the moment of Victoria. But anyway, that's the full house, and that's what we need to work towards. In Victoria, they have been taking a systems-based approach only over a few years. It took a couple of years, took about 2 years for them to work out what the hell to do, to design it. And they were given, they've got about 200 million over 8 years. That might be getting the chop. I don't know whether the Victorian government is now going to pick up the whole that the federal government just created last night in the federal budget. But this minister here, David Davis on the right, he's by far the most astute health minister I've come across in terms of population health. He's a Liberal minister, and he just walks and breathes prevention. He's been fantastic. The guy in the middle is Jamie Oliver, you might recognise, and he has been fantastic in Victoria. And the other fellow is the Premier. So in order to, you know, this has high-level input, and they are champions. So the vision is a sustained activating of systems, not projects and so much programs. And what they did was to get the legislation in place so that local governments not only had the authority to deal in health and operate in health, but also the mandate and the requirement to do it. They have to build municipal public health plans, that's a requirement, and then they got funded to do it properly. So this was taking it down to the local level, because if you want a prevention system, it's outside health. So the health, if the health system wants a prevention system, it better be prepared to send its money outside health. And that's how they're doing it there. Very, very hard to show what this thing looks like, and they've tried all sorts of graphics and all sorts of things, but it's very difficult to show. And they've just ended up showing it as this kind of ecological approach with the different sort of layers of the onion ring. But they've taken 14 local government areas, a little bit like we're doing in New Zealand with the 10 areas. So that's fine. I think that's good to concentrate it. In Victoria, it covers about 1.3 million, so about a quarter of the population, a sizable piece of the population. And as I said before, with the spread, that's going to, with the virus getting out, this is going to spill pretty quickly. Lots of stuff on leadership at every level, Mayor's Network, you know, Jamie leading here, localised websites and so on. So, you know, lots of things, very difficult to show. Characteristics, leadership. Very strong. They have specific leadership programs. The evidence base is interesting, you know. Those demonstration projects that I talked about were critical in getting the belief up that this stuff is doable and have an effect. And then when the minister here goes over to Victoria and sees the stuff in action, even though it's only been going a year or two, he says, there's the evidence. And so the evidence that actually is convincing is showing that stuff is operating and working. We haven't even got to the outcomes yet, but that's fine. Taking a systems approach, scalable, as I said, funding a specific injection, but it's not a lot of money. I mean, the amount of money that is spent, that's about $1 billion. That's a few statins. That's a few statins over a couple of years. You know, 2 statins over 2 years is what this whole prevention budget is. I think we pay less for our statins here, but you know, it's not by the scale of the Vote Health. It's not big, and empowering, as I've said, local government. Key components, champions. Jamie Oliver's been critical. This Achievement Award program, we've got bits and pieces of it in New Zealand. The Heart Foundation runs, you know, the awards for schools and workplaces and things. They've really ramped this up, or they are ramping it up. It's in the process of doing it, and they're seeing this as their quality control system. And not only that, but it also gives you early progress and early results before the outcomes become available. So this award program is, you know, it's a criterion-based thing where you get bronze and silver and gold for your, you know, school or your workplace and so on. It's pretty standard stuff, but having it implemented and supported is critical. 12 sites. In Australia, they randomise pair selection, so there is the potential to do good comparisons. About 100 new staff on the ground. So this Victoria is about the same size as New Zealand. It'll be interesting to see tomorrow what budget they put to it. Training and networks of practice. Evaluation, they have actually tried very hard, but it's fallen short, I have to say. Not through any fault, I think, of the government, but just things haven't worked out. So I think the evaluation we could do a lot better. We have just been able to secure getting opt-out consent for measuring children's height and weight, because that is the outcome we want. That is the believable outcome, measured height and weight in children. And if you can do it with opt-out consent, that reduces the burden on schools, reduces the burden on researchers, and I think that's a real plus. Healthy Families in New Zealand. They've got good, strong links with Victoria, which I think is very positive. MOUs, sharing a lot of material, training and so on. So this has allowed them to fast track it. So we're implementing it in New Zealand in months, which took years in Australia. So that's good and bad, but it's an opportunity. And so now is the political moment, really, and I think Auckland needs to think about how we're going to seize this political moment. There's this political drive from Wellington. There'll be Healthy Families New Zealand, some activity on the ground within Auckland. There'll be some national components, achievement programs and social marketing that Auckland could take leverage of. So the implications for Auckland, I think personally that there are sufficient resources within 3 DHBs, 3 large DHBs, 1 large councils, 3 Healthy Families New Zealand sites, the NGOs, the community groups. There's actually a lot of resources in Auckland. It's a question of the reorientation and application of them. It definitely needs high-level leadership pushing this, because this is messy stuff. There's coordination, there's reorientation, there's getting this new thinking around systems, resource mobilisation. All of that stuff is messy and takes time and effort, but it really needs high-level leadership. It could be packaged as a prevention system for Auckland to give it some sustainability, and I think we do have an opportunity to build a strong evaluation component in it. For Maori and Pacific, again, it's a major opportunity to seize, but I am not certain that Healthy Families New Zealand, it may or may not be sufficient for these populations based on our experience with trying to take these approaches. In my view, we need to have approaches which are absolutely culturally centred. They've got to start off with the culture and build on the strength of the culture. And whether this kind of systems thinking and thinking about culture as a system is helpful, I don't know. It could be. But we shouldn't be kidding ourselves that this is going to be an easy fix for these tougher high-risk populations. But, you know, New Zealand is in a great position in these areas of Indigenous health and Pacific health to be able to lead internationally. So just to conclude, obesity and poor diet are New Zealand's #1 risk factors, and I think that needs to be recognised. Virtually no policy implementation over the last 2 decades, despite the awareness of the epidemic, and that's largely been back pressure from the industry and timidity from government. But now we've got a political window with Healthy Families New Zealand. I think Auckland is big enough to run its own show and capture this, but run its own show. And I think HTV is an excellent model, and but I think Auckland can do better. I think a systems approach for those high-risk populations. I don't think Victoria has a strong handle on that, and also I think the evaluation, we can do it. So if you want my opinion, I say go Auckland, let's do it. Thanks very much. I think the local government policy, there's a lot of opportunity there. If you look at it through the lens of, you know, physical activity and healthy eating and the systems, there's a lot of opportunities there. In my experience, local governments are pretty keen on this space. Actually, they're actually for it, and particularly the physical activity environments and changing those. There's not a lot of opposition, strenuous opposition like there is in the food space. Yeah, there's difficulty around dollars and they've got to go through processes, but there's not that kind of antipathy that we get. For the food policies, it's a different story, I think, and the approach that we're trying to take is around building the evidence. I mean, we can do all of the cost-effective analyses we want, and we can talk about the rights of children and all that sort of stuff, and it just doesn't seem to wash. What we're trying to do at the moment is build up, get the evidence through case studies, actually. That seems to be the evidence that people take notice of. So the fact that Mexico has got through a junk food tax and a sugar-sweetened beverage tax is actually really important evidence that this stuff can be done. And so we're building a kind of a dossier, if you like, of what countries have done great things in this space, so that a little bit like when the minister from here went over to Victoria and kind of saw what was happening, he was convinced, and we've had the same thing happen in Australia. They go over and visit things and they say, okay, yep, that can be done. Went over to New York, saw the kilojoule labelling on the restaurant, said, okay, we can do that. And so I think these case studies are actually where it's at, and that's what we're trying to build, that evidence. So for some of them, like the under fives one in Geelong, where we kind of went in and said, okay, come on guys, we've got to do something with the under fives, but we haven't got any money. That was trying to get the key agencies that were around the table, and just starting off with a coordination effort, actually. Just say, let's all be on the same page and coordinate. With the other one, with the COLAC, where it seemed to spill out into the other region, that wasn't any of our doing. They just saw what was happening. They're smart people, and they mobilised their own resources to do it. And I don't think it takes a lot of resources, but it does take a degree of high-level leadership and commitment to kind of get organisations together. And in some ways, this is kind of the beauty of a systems approach, I think, because with a systems approach, these 100 people, these 100 new people, they're not coming bringing programs. They're coming and they might sit with not a program for school food, but they might come in and sit with a principal and say, draw us your system for school food. What does it look like? Who makes the decisions? Where does the food come from? Where's the demand? Where do the parents fit? Where does the school board fit? And that sort of stuff. And where are the levers for change? And if you need some help, actually there are some programs over there that you can call in. And so it does help with these kind of logos and people's things, because you're going a next step upstream and looking at the system. So I think it would have been more helpful, I think, if we'd had that thinking at the time. Yeah, it's a very good question, William, and I'm not entirely sure about that. I mean, I think if we consider this as the start of building a prevention system, just like we've got a disease treatment system all around us, we need a prevention system. I think you do need to bring in those other risk factors, because those are the big ones. And in some ways, there is the potential in prevention to do this kind of leapfrogging. If they can do this in alcohol and restrict premises and outlets for alcohol, why can't we restrict having McDonald's next to the school? Type of thing. So there may be parallels and leapfrogging that we can do, and might add strength to it. I hope it does. But yeah, I think if we're thinking about this in a prevention system approach, it makes sense to bring those in.